Good evening, everyone, and warm welcome you all to this teaching session of SNCC. And today's topic will be on management of acute spinal cord injury. Srinidhi will be presenting this topic. It's a case presentation. I request all of you to be interactive. I think there are very few person, and I request all of you to label your name properly. One is a Zoom user, the other is DK. So if you could identify yourself, probably it will be easy to discuss. Thanks Adira and Gopi for joining, and request all of you to be interactive as much as possible. Over to you, Adira. You can go ahead with the presentation.
Good evening, sir. Good evening, everyone. Today's case presentation is on traumatic spine injury. My moderator is Dr. Shivakumar, sir. My case is a 32-year-old male with no known comorbidities. He works in a factory. He had come with an alleged history of accidental fall from 10 feet height at his workplace, sustaining injury to his neck. He had loss of consciousness. Initially, he was taken to a local hospital in a gasping state with hemodynamic instability. He was found to have quadriplegia and fecal incontinence. He was intubated and ventilated, resuscitated with IV fluids, and since he had anemia, they transfused 2 units of PRBC, and he was initiated on vasopressors for maintaining adequate blood pressure. He was treated with anti-epileptic drugs and antibiotics. He came to RCH, our hospital, on the same day for further management. On arrival to our hospital, his GCS was E3-VT-M1. Bilaterally, both pupils were equal and reacting to light. He had tachycardia with a heart rate of 120 beats per minute, and saturation was about 95% with 100% FiO2, and PEEP was 6 centimeters of water, and respiratory rate of 24 breaths per minute, and a tidal volume of 400 ml. He was hypotensive with a BP of 80 or 60 millimeters of mercury. Invasive lines were placed, and vasopressor supports were initiated to maintain a MAP of 85 to 90 millimeters of mercury. Cervical collar was placed, and log roll was maintained.
Srinidhi, we'll stop here. Can
Yes,
you go
sir.
back to the previous slide?
Yes, sir.
Okay, so this patient had a fall from height and went to a outside hospital, then subsequently came to your center. Okay, right? So
Yes, sir.
there he was quadriplegic and he was hypotensive and he was in a gasping state. Okay, right? So
yes, sir.
So your clinical diagnosis at this point, even before you go ahead with the imaging, what will be your clinical diagnosis?
As he had quadriplegia, we can suspect spinal cord injury, sir. And he was in a gasping state, suspecting a traumatic brain injury, sir. And since he's hemodynamically unstable, internal bleeds should be suspected, sir.
Okay. Okay. So you're suspecting a spinal cord injury along with the traumatic brain injury, and you're also suspecting a hemorrhagic shock. Okay, right?
Yes, sir.
So what do you? I think I want others also to interact. Lenin, Dinesh, Hari. Lenin, are you there?
Sir, yes.
Lenin, I think I remember discussing this topic earlier also.
Yes.
I think maybe earlier Adira presented and we discussed. So here, do you think that shock is entirely neurogenic, or how do you want to approach shock in these patients? The suspected cervical spine injury, do you think that shock is entirely neurogenic, or you want to rule out other causes like any other polytrauma patient?
First, we should approach. I was not in the previous slide, sir.
Okay. Okay.
To be approached to shock in a patient with polytrauma, first we have to look for hypovolemia shocks because of hypovolemic shock. The neurogenic shock. Neurogenic shock usually associated with it's because of distributive shock. It is associated with the low SVR.
Okay.
Bradycardia is not a bradycardia is not a predominant feature, but patient with warm skin. With
Yes,
low
sir.
SVR.
Just
See,
We can think about neurogenic shock, sir. Yes, sir.
Yeah. Why I want to bring in this discussion is, though I think it looks like a clear-cut high cervical spine injury and it is a neurogenic shock. See, probably these patients could have other type of shock as well. Probably
Yes,
you should troubleshoot as in like any other polytrauma patients. Hypovolemic shock needs to be ruled out and probably an obstructive shock needs to be ruled out as well. So though it could be a cervical spine injury, probably they might have other type of shock or sometimes mixed type of shock as well. So the approach has to be
holistic.
in that context. Okay, right. So next, moving on, Hari or Srinidhi, do you have
Yes,
what?
sir.
I think with this clue, I think we discussed that the shock could be multifactorial even in this patient. I think with the hemodynamic profile you're giving, what is the type of shock you're thinking?
Sir, hypovolemic hemorrhagic, sir.
Why? What are the things in favor of?
Initially, in a local hospital, they have initially resuscitated with fluids, sir. Even with fluid resuscitation, initially BP was maintained, and then only they started on vasopressors. So he is volume responsive, sir. And second, he had anemia, sir. So probably source of bleed has not been identified, sir.
Okay.
And
Anything which goes against neurogenic shock here?
Heart rate was around 112 beats per minute, sir.
Okay.
Usually, if at all neurogenic is there, bradycardia can be associated, sir.
Okay.
Then,
Yes, Dinesh.
sir, the patient is also having a narrow pulse pressure.
Okay.
So again, the patient had a fall from the height with injury to the neck and head.
Okay.
We have to think of the hemorrhagic, which includes the vascular injuries to the neck. So since the patient is having a narrow pulse pressure and tachycardia, so we
Okay.
have to keep that aspect in the mind, even though the quadriplegia pointing towards a cervical cord injury. So
Very
because
good.
of the narrow pulse pressure, we have to keep that that also in the minds.
Yeah. See, the fact that he is tachycardic and pulse pressure is narrow, it says that it is entirely not a neurogenic shock. You may have a mixed type of shock here. And this is very important. I think many a times you should not approach it like a pure neurogenic shock. So these patients may have different type of shock. Sometimes the combination of shock can be there. So that has to be kept in mind. Okay, who else is there? Hari?
Sir?
See, he is fluid resuscitated. Assuming this to be a spinal shock, I think he has received fluid boluses, and despite that, he is bradycardic and probably is having a blood pressure of 80/60. So, what is the hemodynamic target you would like to achieve in this patient, assuming this is a spinal cord injury and he is in spinal shock? I think we will not take other shocks for discussion now. So, assuming it to be a neurogenic shock, and so what you want to do, what will be your hemodynamic target?
Sir, maintaining a map of around 75 to 80 for the first 7 days, sir, assuming spinal.
Okay.
So we'll be starting with noradrenaline, Persisting
Okay.
body is will add on adrenaline, sir.
Okay. So I think the most important thing will be, I think your focus should be to prevent a secondary injury.
Second
And
injury.
in that context, you need to maintain a systolic BP more than 90 or a MAP close to 80, 85. So
Yes.
that should be the target to prevent a secondary spinal cord injury. And apart from fluid resuscitation, so your choice of inotropes and vasopressor will depend upon the level of injury. So probably if the level of injury is mid-thoracic or lower, probably you can go with the pure alpha agent.
Okay,
And
sir.
probably if it is a higher level of injury, you can go with an agent which has got both alpha and
Big
B.
one.
Yeah. So that should be your approach. So I just want to tell you two things. One is shock. These patients will have shocks of varied etiology. Keep that in mind. And the other focus will be to prevent secondary insults. So you need to achieve your hemodynamic target very, very early, as early as possible.
Okay. Okay.
Okay, Srinidhi.
I'll proceed, sir.
Yeah, please.
Regarding his history, past history, he did not have any known comorbidities or injuries or previous surgeries. Personal history, he's a smoker. He's having mixed diet, normal bowel and bladder habits. Family history, nil significant history.
Okay.
Coming to neurological examination, his higher mental functions we were unable to assess. Mental status was abundant. Cranial nerve examination was we were not able to complete the complete cranial examination.
Hello?
Pupillary reflexes.
Hello.
Pupillary reflexes were preserved. Corneal and conjunctival response was preserved. Plantar showed extensor response. Motor examination, power, tone, and were decreased in all limbs. Coordination and gait we were unable to assess. Regarding a spine examination, we maintained the log roll. There were no external wound or warmth in the spine region. Central tenderness was present in the C5, C6 region. Sensory response below T4 was absent, and there was motor deficit. He was quadriplegic. Voluntary external anal sphincter contraction was absent.
Okay, proceed.
Coming to sensory examination, regarding his right side, upper limb and lower limb, pinprick, light touch, position sense, vibration sense, and object discrimination, there was no sensation. Whereas coming to left lower limb, the same pinprick, light touch, position, vibration, and object discrimination, he had no sensation. Other systems, regarding CVS, S1, S2 was heard, no murmurs. Regarding respiratory system, right side air entry was present, left side comparatively it was reduced. Lung sliding was absent in left side, and X-ray showed moderate left side hemopneumothorax. Coming to per-abdomen examination, no external injuries were seen, and abdomen was soft, no free fluid in ultrasound.
Srinidhi,
yes, sir.
We'll stop here. Dinesh or Lenin or Hari, nothing. Rohan, can you go back to the previous slide? Or next slide, yeah. Next slide. Next slide.
Yes, sir.
Next slide. Next slide. Systemic examination.
Yes, sir.
Okay. Hari.
Yes, sir.
Hari,
Sir.
she mentioned that abdomen there is soft and abdominal examination was non-contributory. In this patient context, anything you like to keep it in mind?
Yes, sir. We'll see focus on EFAST. Fast will be
As far as
usually
clinical examination is concerned.
You should check the anal tone
Very important, very good. I think
Yes, there is
unless
a
you do,
C5 involvement. There is CFI involvement, or phrenic might be involved in, sir. Patient might have abdominal breath.
okay.
Yes.
Anything else?
Bladder.
See, many a times, I think if it is a cervical or higher thoracic injury, and see, clinically, you may not be able to elicit you may miss findings in abdominal examination. You may not be able to appropriately elicit abdominal clear-cut findings for an abdominal injury. You might miss that you need to keep it in mind. So your tenderness or guarding, all that, you may not be able to appropriately elicit, particularly if these patients have a higher cervical or a thoracic injury. So that needs to be kept in mind, and the findings may not be very classical.
Okay.
Okay, Srinidhi, go ahead. Gopi?
Yes.
Gopi, are you there?
Yes, sir.
Gopi, you can feel free to interrupt. Adira, you can feel free to interrupt. And if you want to discuss anything, we can discuss. So,
Yes, sir. Yes, sir.
Gopi, feel free to interrupt and discuss if you want to discuss anything, Gopi.
Yes, sir. Yes, sir. Yes, yes, sir.
Yes, Srinidhi.
Yes, sir. On evaluation, a complete blood count was done. It showed anemia. We transfused 1 unit of PRBC, and renal functions, electrolytes were normal. Ultrasound abdomen was done, which was normal, no free fluid. ABG showed acute metabolic acidosis, which was compensated. Chest X-ray showed moderate left-sided hemopneumothorax. ICD was placed in the emergency department. Echo showed normal LV function. ECG showed sinus tachycardia, no abnormal rhythms. This shows the ABG of this patient during the ICU stay. The initial ABG showed severe metabolic acidosis, which was uncompensated, and he also had hypercarbia, that is 67.8 PCO2. We adjusted the ventilator parameters, and the subsequent follow-up ABGs were resolving. This shows the lab parameters. Initial HB was around 7, and after transfusion, he had a hemoglobin of 8.3, and hemoglobin was maintained throughout the ICU stay. Platelets and other lab parameters were stable. Initially, he had an AKA with creatinine of 1.4, and gradually it resolved. Coming to imaging, in EMD, due to moderate left hemopneumothorax, ICD was placed. This shows previous the X-ray before ICD placement and the X-ray after ICD placement. After ICD placement, the pneumothorax resolved. We took a CECT whole body. Brain showed acute infarcts in the left MCA territory and small acute infarcts in the left PCA territory. V1 and proximal V2 segments of the left vertebral artery showed possible signs of dissection, and there was a mild diffuse cerebral edema. There was no herniation or hydrocephalus. This shows the video of the CT brain. Coming to cervical spine, there was dislocation of bilateral facet joints at C5, C6 level with significant widening and distraction injury. Retrolisthesis of C5 over C6 vertebral body with associated spinal canal narrowing. There were small fractures involving the superior facet of C6 vertebral and adjacent C5 vertebra. Spinous process from C5 to D5 levels fractures. Left transverse process fracture of C5, C6, and C7 vertebra. Regarding chest, there was mild
Srinidhi, we'll stop
border.
here.
Yes, sir.
Stop here. Can you just explain what are the different types of radiological investigations you do in C-spine injury, and what do you look for, and what is the sensitivity and specificity of each of it? We'll start with the X-rays and
X-ray, AP view can be taken in, sir. Bony deformities like subluxation or fractures or interspinous process distance can
what
be
are the
identified
aspects
in
you look
X-ray.
for in X-ray? See, what are the aspects you will look for in an X-ray?
Regarding the anatomy, sir, whether the spinal column is intact, whether a vertebral body, any fracture is there, the intervertebral body distancing, sir, interspinous process distance, any fractures in the transverse process.
Anyone just want to? Yeah, Dinesh, please.
We can see the fractures, whether it is a displaced fracture or a undisplaced fracture.
Okay.
And then what part of the vertebra is involved, whether it is a body or just a transverse or spinous process, and whether there is any these two things. Thank you.
See, where you look for multiple things in an X-ray, starting from the alignment to bony abnormalities to cartilage, disc space, soft tissue. These are the various aspects you will look for in X-ray. To start with, so how do you say that particular cervical spine X-ray is adequate? Anything which would give you a clue that whether this X-ray is adequate or not? Srinidhi?
Sir, two vertebrae above and below should be covered. Exposure should be optimal, sir.
Okay. So you should be able to see the upper border of T1 to say that this is an adequate cervical spine X-ray. So if you're able to see the upper border of T1, then probably you can say that that is an appropriate C-spine, right? Next is, what are the alignments you look for? Anyone can tell. Lenin or Hari? Rohan, you want to come in?
Sir, we'll be looking for any loss of lordosis, malalignment of the vertebra, and anterior atlanto axial joint alignment.
See, basically, you look at three aspects for an alignment. You look at the anterior vertical line, and you look at the posterior vertical line and the spinolaminar line. So, of these three, the posterior vertical line is more significant because even if the X-ray is taken oblique or if there is a bit of rotation, this will not change much. So, in alignment, you have to look at three specific aspects: anterior vertical line, posterior vertical line, and the spinolaminar line. And the most important aspect to look for in that will be the posterior vertical line. So second thing is alignment. Then bony abnormalities, we discussed multiple things, and the next things are cartilage, and you look at the disc space, and also you look at the soft tissue. So these are the various aspects you need to look into the X-ray. And we all know that the most important imaging would be a multiplanar CT. And if you're looking at particularly a soft tissue, then probably you go for an MRI. Or if you have a negative CT and patients have deficit, probably you need to go for a MR. So, anything, Adira, you want to add as far as the imaging is concerned?
Nexus and CCR we can add, sir.
Yeah. do you want to elaborate on that, the sensitivity and specificity with regard to both of it, and what is Nexus, what is Canadian C-spine, and the sensitivity and specificity with regard to both?
For Canadian C-spine, CCR does not include children less than 2 years old, and included very less number of people, very less number of children who are less than 9 years old. Nexus does not include children at all. Basically, the sensitivity of CCR is 100%. For both, almost it is 100%. For CCR, it is 100%, and for Nexus, it is 99%. But specificity is much better with the CCR. So it is better to go with CCR.
Okay.
Canadian C-spine rule.
Okay.
There are 3 parameters, like any high risk factor for that mandates radiography, like age more than 65 years. Any dangerous mechanisms include fall from height, like more than 5 stairs or more than 1 meter, or recreational motor vehicle collision, or a bicycle collision, or any motor vehicle collision with high speed, like more than 100 km/h speed, or rollover injury, or the passenger is ejected from the vehicle. All these include dangerous mechanisms of injury. And if the patient is having any paresthesias or numbness in any of the limbs, that also a high risk factor for which is warranting radiological evaluation. If the patient is able to ambulate at any point after injury, or if the patient, that is a simple rear end collision, or if the patient is able to sit, or if there is that if patient is having pain, but that is a delayed onset pain, or and if the patient is not having any midline cervical tenderness, if patient meets all these criteria, then we can ask to the patient to patient himself to rotate, flex, and extend his neck, and then we can consider not to go for any radiological evaluation. If any of this is present, then again we have to consider radiological evaluation.
Okay. Thank you, Adira. Thank you. You proceed, Srini.
Yes, sir. Regarding chest injury, there was a moderate to gross left hemopneumothorax with significant mediastinal shift to the right. ICD tube was in situ, and adjacent associated mild chest wall emphysema and edema. There was complete collapse of left lower lobe with maintained airborne. There were multiple fractures involving the lateral and posterior aspect of the left-sided ribs. We took a follow-up CT on the next day, CT brain, which showed stable changes compared to previous CT. There was the cerebral edema was mild interval decrease in cerebral edema. Other features were stable. Regarding cervical spine, the follow-up CT showed dislocation of the bilateral facet joints as mentioned above, with the widening and distraction of the C5 to C6 level. Retrolisthesis as mentioned previously, which was stable. We took an MRI spine because quadriplegia was persisting. MRI spine showed significant widening of the disc space between C5 and C6 vertebral bodies, with the interspinous space between C5 and C6 processes suggesting of distraction injury, with rupture of the C5-C6 intervertebral disc, and anterior longitudinal ligament, posterior longitudinal ligament, and the ligamentum flavum and interspinous ligament were ruptured. The cervical spinal cord at the level of C5-C6 was swollen. Diffuse T2 hyperintense signal showed cervical cord from C2 to C6 levels contusion. There was no blooming within the cervical cord suggest hemorrhage. Only edema was present. Mildly displaced fractures were seen in C5 vertebra spinous process, and displaced fractures were seen in the spinous process of C6, C7, D1, D2, D3, D4, and D5 vertebral bodies. And other fractures noted were left transverse process of C5, C6, C7 vertebra. Regarding the summary of the cervical spine in MRI, C5, C6 level showed cord contusion and ruptured intervertebral disc and rupture of the anterior posterior longitudinal ligaments, ligamentum flavum, and widening of C5, C6 disc space. Regarding management, we have transfused 1 unit PRBC, and post-transfusion hemoglobin was static, and shock resolved with fluid resuscitation, and minimal vasopressor supports were maintained. Follow-up ABG showed resolving metabolic acidosis. He had bradycardia, and hence orsipinolene was added. We maintained MAP, and urine output was maintained of more than 0.05 ml per kg per hour. Feeds were optimized, and glycemic control was optimized. Analgesics and antiepileptics were continued. DVT prophylaxis was optimized. We took follow-up CT thorax post-tracheostomy, and image of this X-ray shows post-ICD removal status, since the follow-up CT thorax showed resolving pneumothorax. And after the initial stabilization phase, he underwent C5, C6 anterior cervical discectomy with spinal fixation. During this procedure, there was no adverse events noted. This image shows the fixation screws in the X-ray.
Srinivi,
Yes, sir.
so I'll just, can you stop here?
Yes, sir.
Lenin,
Yes, sir.
see, what will be the purpose of surgery in a spinal cord injury? So, what are the indications, or what reasons for which you do a stabilization?
It's mainly to avoid the secondary injuries.
Okay,
So
the main purpose will be to avoid secondary
avoid
injury.
secondary
What
injuries.
else?
We need to align the spinal cord so that the extra injury to the spinal cord is could be avoided, and that induced edema and cord compression can be avoided, sir.
Okay,
Right.
so the basic purpose will be to reduce the secondary injury, one, or else to give a stability,
Stability,
right?
sir.
Or for purpose of decompression. In that context, it has to be done ideally within 24 to 48 hours.
Okay.
Is there any benefit of doing an early decompression compared to a late decompression? Dinesh?
Sir, early decompression might prevent a progression of the neurological deficit if it is a partial deficit.
Is there any survival benefit? Is there any non-neurological benefit?
Non-neurological benefit I am not aware of, sir.
Rohan?
Sir, I'm not aware of non-neurological benefits.
So basically, as Lenin said, the surgery is to reduce or prevent secondary insults, to provide decompression, and to give stability. These are the reasons we do surgery. So ideally, it should be done in an early time frame. Though there are no survival benefit, definitely there are some non-neurological benefit, like they stay less on ventilator, they have a less ICU stay, infections complications are lesser. So there are many non-neurological benefit, though there is no survival benefit. So there are certain non-neurological benefit when you try to do these decompressive surgeries in an earlier time frame. Okay. Okay, Srini.
He was continued on anti-epileptic levetiracetam. Orsipinol was continued in view of bradycardia. Analgesics, paracetamol, fentanyl patch was used. Supplements like vitamin B was added. DVT prophylaxis was changed from heparin to clexane. In the due course, electrolytes were corrected. Daily physiotherapy and weaning was continued, and despite which quadriplegia persisted. He underwent a surgical tracheostomy. He started obeying, and his hemodynamics were stable. weaning proceeded gradually to truck mask and BiPAP, and he was shifted to ward for further management. Coming to the diagnosis, diagnosis is polytrauma associated with traumatic brain injury and traumatic spinal cord injury with quadriplegia, and left-sided moderate hemopneumothorax. Post ICD status, it resolved, and status post C5 C6 anterior fixation was done, and post tracheostomy status.
Can you stop screen sharing?
Yes, sir.
Okay. If you all don't mind, can you switch on your cameras, please? So if you're able to, so that we can. Thank you, Dinesh. Others also, if you could, probably. Okay. See, few other aspects to discuss. Whenever you have a patient with TBI, probably these patients may have an associated C-spine injury also, and C-spine injury has to be suspected and ruled out. And whenever they have a cervical spine injury at one level, probably they may have a cervical spine injury at another level also. So these are all important aspects which you need to keep it in mind. And the pre-hospital goals of care will be similar to your hospital goals of care, like preventing secondary spinal cord injury. That will be your goals of care. And sorry, I forgot to switch on mine. So this will be your goals of care. And during shifting, you should have you should take precautions to stabilize them, and they should have a collar, and they should be on a firm board, and there should be strapping at multiple levels to give them stability during transfer. But as soon as they reach the hospital, and once you assess them, I think you should remember to remove this spine board, because these are very rigid and probably this can give rise to pressure ulcer. So this has to be removed at the earliest time window where you're ruled out and you stabilize these patients further. So the other areas of discussion is how do you assess their respiration and at the bedside, and probably when do you think of ventilating this patient, and once you decide to ventilate this patient, what precautions you take, and how do you ventilate these patients, how do you intubate and ventilate this patient. Rohan, you want to elaborate on that? So what precautions you want to take when you intubate this patient? How do you, if it is an Shobana, can you mute your phone? Yes, Rohan, you have to unmute yourself.
So the first thing and the foremost thing that we need to keep in mind while intubating such patients is that the spinal axis has to be immobilized at all points of time. The conventional sniffing position that we achieve for aligning the laryngeal pharyngeal axis should not be done, and primarily if video laryngoscopes are available, they can facilitate the glottic visualization without aligning the achieving the sniffing position. And another thing, if we look at the drug part, while induction cardio stabilizing agents like etomidate should be preferred, because since this patient, the example which was given, the case presentation was hemodynamically unstable, so minimal necessary dosing. And since we do not know the NPO status, probably RSI would be a better option for intubating such patients.
Lenin or Hari, you want to add anything with regard to the intubation.
Regarding airway, if the spinal cord injury is not, unless it's proven, we should take it as spinal cord injury. And when there is need for airway manipulation, patient should, it should be done under Mills procedure, manual inline stabilization procedure. It requires 2 to 3%, 2 to 3%. So, and if it is a center which we can use a video laryngoscope, by all means we can do it with the assisted video laryngoscope intubation, sir. And also, as he told us, we can use a rapid sequence intubation, this kind of things.
Dinesh, anything else you would like to add?
The same like a previous like Mills position and RSI and prevent hemodynamic deterioration with early use of the liberal fluids and vasopressors to maintain the map.
So you have to do a manual inline stabilization, and probably if you're trained to, you can use a video laryngoscope or a fiber optic bronchoscope and intubate this patient. The other thing you need to keep it in mind is many of these patients will have a parasympathetic overactivity, probably, so they may develop a severe bradycardia whenever you're trying to intubate this patient or you're trying to suction this patient. They may have a parasympathetic overactivity that you need to keep it in mind whenever you're intubating these patients. The other things are, see, how do you assess these patients and how do you assess their injuries and various types of syndromes you should be aware of. I'm sure all of you would be aware of various type of spinal cord syndromes, and so based on the clinical presentation, you should be able to localize the different types of syndromes and the track they are associated with. So I'm sure, Rohan, are you all familiar with various types of syndromes associated with spinal cord injury? Rohan?
Anterior.
Yeah, Dinesh, you can elaborate on that. Yeah.
There are different syndromes: the anterior cord syndrome, posterior cord syndrome, central cord syndrome, and Brown-Séquard syndromes. These are the 4 syndromes.
Good. So you know their clinical presentation?
Sir, Brown-Séquard syndrome is, I think, ipsilateral motor loss and ipsilateral fine touch and vibration test loss and contralateral pain and temperature.
Okay. Rogan, you want to, how does the central cord syndrome present with?
Central cord will not have a motor weakness.
Is it so?
Syndrome.
Posterior cord will not have a motor weakness.
Motor
Okay.
weakness. Yes.
So central cord, usually the involvement will be more of a upper limb and lower limb will be spared. That is very classical of a central cord syndrome, and most of these patients have a better prognosis compared to other type of spinal cord syndrome. So they will present with more involvement of upper limb compared to lower limb, and usually they do well compared to other spinal cord syndromes. Adira, you want to add anything?
No, sir.
Apart from trauma, any other non-traumatic cause of spinal cord injury you can think of? Commonly, what we come across is spinal cord injury secondary to trauma. Any other non-traumatic causes you can think of?
Spinal cord injury because of the metastasis related fracture causing the compression.
Good.
And then only spinal cord injury you are asking, sir?
Yeah. Other non-traumatic causes for spinal cord injury.
Infectious tuberculosis, patients of port spine.
Yeah.
And vascular injury in a major aortic surgery like the anterior spinal artery
Yes.
occlusions.
So it could be due to spinal tumors. It could be due to vascular pathologies. It could be due to degenerative diseases, and very rarely it could be secondary to a autoimmune causes as well. So these are some of the non-traumatic causes you will think of in a patient with spinal cord injury. So I think we discussed most of it, and fewer basics like based on the mechanism of injury, what type of mechanism is associated with cervical, what type of mechanism is associated with thoracic, and so these things I'm sure all of you know. So hyperextension is usually secondary to a facial or frontal trauma, and usually you get a lower cervical spine injury. And wedge compressions are common in thoracolumbar, and if it is displaced, particularly in a thoracic spine, they usually have a deficit because at the thoracic cord level, probably the spinal cord is very narrow. So whenever there is a dislocation at this level, usually it is associated with a deficit compared to other areas.
Is there any role of steroids in preventing secondary spinal cord injury?
I think this is quite controversial. As far as the exam point of view, you're supposed to know that these three trials, NASIS 1, 2, and 3, and what they have looked at, and what is the inference from the three trials. So you need to know. And though the NASIS 3 probably there shows some benefit, but most of the meta-analysis or Cochrane analysis did not show any benefit with the, on the contrary, there are more infections, more GI ulcers, bleeding related issues. So, but at least from the exam point of view, try to know these three trials and what they have done in these three trials and what is the outcomes of these three trials. Try to know that. But in general, probably there's not much of benefit with high dose steroids, even if they present early.
Okay.
And the other aspects of discussion is the pain control. The one, apart from the regular multimodal analgesia you provide with, these patients may have a lot of neuropathic pain. So probably gabapentins and tricyclic antidepressants might have a role in these patients. So behavioral therapy, all this will have a role in long run in these patients with spinal cord injury, as many of this, they do have a bit of neuropathic component, so they will benefit from gabapentin, tricyclic antidepressants, and behavioral therapies. This is something to keep it in mind. And other area of discussion is DVT prophylaxis, nutrition. Nutrition is like any other trauma patient. These patients will be catabolic, and probably you should try to attain the target and calorie and protein requirements at the earliest. And these patients are at high risk of DVT, and so they need to be started on mechanical prophylaxis at the earliest. And once the acute period is sorted out and there is no, you're not planning for a surgery, then probably you might go for a pharmacological agent at the earliest. And low molecular heparin has been superior to conventional heparin in this group of patients. And there are a lot of papers about the use of newer anticoagulants in these patients with spinal cord injury as well. In long run, many of them are switched over to newer anticoagulants from heparin. So these are the other aspects. Adira, you want to?
Sir, autonomic dysreflexia we didn't discuss.
Okay. We can discuss.
Okay. Autonomic dysreflexia is common in patients who are having injury at the level of T6 or above. Usually these patients will have symptoms like headache, hypertension, associated with bradycardia, flushing, anxiety, nausea, all these symptoms, which is commonly related to a stimulus which is originating below the level of injury. Most probably, and the patients will not be able to appreciate their symptoms. For example, if there is any tight clothings, an impacted bowel, or if there is bladder retention, or if there is any painful stimulus which is actually below the level of T6. It is very important to rule out all this, because these things can potentially cause life-threatening injuries like stroke, seizures, myocardial infarction, and pulmonary edema. So we have to remove the precipitating stimulus. Then, if it is still persisting, you can go with some short-acting drugs for hypertension, short-acting drugs for tachycardia. You have to catheterize the patient if the bladder is distended. You have to remove the impacted stools if the patient is having issues because of the impacted stools. This is one aspect we didn't discuss.
Okay.
That's all.
I think we are running short of time. The other complications are like urinary tract complication. Many of them, because of the imbalance between sympathetic and parasympathetic, they may have a neurogenic bladder, and the detrusor will try to contract against a closed sphincter, and these patients will have a high bladder pressure, and many of them will have a reflex as well, and they are prone for UTI. So these patients, high cervical spine injury with patients, probably they may go for a SPC, and probably this is associated with less amount of UTI compared to a Foley's catheterization. Or if the level of injury is at a lower level, probably they can go for a self-intermittent catheterization. And spasticity is very common in these group of patients, and many of them will benefit from a baclofen. So these are the other aspects or other complications of spinal cord injuries. Lenin, Dinesh, Hari, Rohan, anything else you would like to discuss? Lenin, you're muted.
No, sir.
So this will be even if it is for an exam, it will be a very straightforward case, and probably they will discuss about radiology. They will discuss about the level of injury. They will discuss about intubation and ventilation, and probably about the complications of spinal cord injury. So these are the various areas of discussion, and probably you should be familiar with the literature around this, and the timing of surgery, and the use of steroid, and the literature related to the steroid use, that NASIS 1, 2, 3. So these are the literature you're expected to know.
Okay.
Brief clarity about the prognostication, early prognostication or early prognosis of the spinal cord injury condition, sir.
Sridhar, you want to answer this?
Prognosis related, I have no idea.
Adira? Lenin, I'm not sure about any validated systems for prognostication. Let me check, and I'll update in the group.
Okay.
The basic factors taken into consideration are their age, their comorbidities, the level of injury, and associated injury. So these are the factors taken into consideration. Let me check whether there are any validated systems to prognosticate these patients. I'm sure should be available. Let me check and get back to you. Thank you, Srinidhi. Thank you. And thank you,
Thank you,
everyone.
Thank you, sir.
Thank you.
Thank you. Thank you.